For the first nephrology rheumatology grand rounds, we have Dr. Kim from Barnes Jewish Hospital at Wash University in St. Louis. So Dr. Kim is a adult rheumatologist.
Hey now.
Yeah, a rheumatologist who also is the director of the Lupus Clinic there. He has a research program on human unmet needs in human SLE. With a focus on complements, both as a biomarker and its biology. He's also looking at, the immunogenicity of vaccines in SLE right now with an ongoing COVaRiPAD study. But without much ado, I would like to invite him to talk about, we have, after a long time, we have some new agents in SLE, and Al has some experience in this. So I'll ask him to go ahead and welcome. As a housekeeping note, this presentation is being recorded. It will be available later on our YouTube channel. And everyone, please mute yourself. Thank you.
All right. Thank you so much, Swapnil. And again, thank you again, Catherine, for coming up with this really great idea. I mean, again, I think these cross-disciplinary discussions really highlight kind of unawareness of each discipline's, really strengths, in the inner workings. But as a result, it's a great educational opportunity for everyone. So as Swapnil mentioned, we'll be talking about some of the newer therapies that have come out in lupus. Lupus has been a disease that has been devoid of, at least in U.S., FDA-approved therapies. Prednisone and hydroxychloroquine were approved in the 1950s, and then it wasn't until 2011 when Belimumab was approved for systemic disease. And then over the last few years, we've had a rush of new agents that have been coming out. So we were just talking before the discussion here that this is a very unusual time for us people in lupus, that we're actually talking about new drugs as opposed to theoretical benefits observed in mouse models. All right, so I do have a couple financial interests I want to disclose. The two main medications I'll be talking about today is going to be Belimumab and Voclosporin. Hey, guess what? I have research funding and/or personal fees from both. I've done my best to eliminate any bias. If there's any bias detected, please mention that and allow me to be able to improve the discussion. All right, so a couple objectives to be able to highlight today. First is to develop a treatment plan for lupus nephritis patients based on the most recent lupus nephritis guidelines. Of course, these guidelines are going to be different as newer agents come out, but at least based on what's out there right now, we can develop at least a concrete initial plan for all of our patients. The second, though, is going to be the highlight of this discussion, is going to be comparing the efficacy and safety data between Belimumab and Voclosporin for the treatment of lupus nephritis itself. So I stole a fair number of slides here from Maria Dellera at UCSF, who gave a very nice talk about lupus nephritis at the American College of Rheumatology Winter Symposium a couple months ago. So since she did such a great job, I just decided to use some of those slides. And one of these is going to be talking about these guidelines and how it's evolved a little bit over time. I'm going to just focus on the most recent ones. I'm not going to even talk about the older American College of Rheumatology one, because that's about 10 years old and honestly is outdated. But the 2019 EULAR, ERA, EDTA recommendations, I think highlight several different paradigm shifts in terms of how we treat lupus nephritis versus how I treat lupus nephritis when I was a fellow in rheumatology. So really, one of the things that highlighted was that the goal of treatment really is going to be this urinary protein creatinine ratio, ideally collected from a 24-hour urine, with a treat to target of somewhere between 0.5 to 0.7 grams by 12 months after an initiation of treatment. I'll go into why this is such a weird biomarker in a second. It's not the best. Obviously, you have to wait 12 months before you realize whether or not a certain treatment regimen is efficacious or not. And again, this highlights some of the problems in lupus nephritis. The second is much more aggressive use of lower dose glucocorticoids. And I think one of the biggest things we highlight in systemic lupus is this concept of damage. So disease activity we think of as reversible organ injury. Damage is irreversible organ injury. And much of the damage that is accrued in lupus, and much of this data was obtained in the University of Toronto, is due to glucocorticoid utilization. So this is really highlighted amongst the lupologists, is that we really need to be using much less initial glucocorticoids. So the initial dose has been recommended of IV methylpred of less than 2.5 grams total, not so basically during the early induction phase. And then when you switch over to oral glucocorticoids such as prednisone, we need to be using lower than prior guidelines. And this includes some targets for dose reduction, which I'll talk about in a second. I can tell you here at Washington University, one of our goals for any lupus admission for flare is we're going to try to get them down to 5 milligrams or less of prednisone a day within 6 weeks. That's our goal here. The urolupus dosing for cyclophosphamide is recommended instead of the high dose. So again, this is highlighting the reduction in dose in order to reduce any adverse issues complicating therapy. And then the other thing too is initiating combination therapy also as an alternative. In this case, they recommend mycophenolates, calcineurin inhibitors, and glucocorticoids as another alternative. So I think again, this highlights several different paradigm shifts. Instead of more sequential or kind of thinking linearly about things, it highlights reduction in some aspects, intensification of other aspects, kind of all at the same time. All right, so just when you graphically kind of put this out, the glucocorticoid induction phase occurs here on the left side. The IV methylpred is going to be no more than 2.5 grams total. You transition to oral prednisone or prednisolone, depending on their tolerance or effectiveness. And then this is going to be dosed here up to 5 mg per kg per day for a month. And then you taper down by 3 to 6 months to 7.5 milligrams a day. And during this time, you're going to be starting immunosuppressive therapy to reduce glucocorticoid burden, and that's going to be either the low dose cyclophosphamide, mycophenolate, or mycophenolate plus calcineurin inhibitor. Once you get through the induction phase, then you hit maintenance treatment. It's relatively vague, but essentially choosing between mycophenolate or azathioprine. Hydroxychloroquine continues to be the cornerstone of lupus therapy. It's the only therapy that has demonstrated repeatedly a survival benefit. No other medication, interestingly, has been able to demonstrate that. And there's also some significant advantages, particularly in pregnancy with lupus. There's a wonderful, the Neff Madness lupus bracket. Jason Kidd's done a wonderful job of explaining this in his commentary. So KDIGO, the 2021 guidelines then came out. And I think the only thing that I want to highlight here is going to be at the bottom here. Again, it highlights reduction in glucocorticoid burden, but there's a lot more options to use here. Calcineurin inhibitors are kind of put into this first line, also with B-cell targeting agents, whether it's going to be Belimumab or rituximab. This is quite a bit different than how we practice in the US, where again, I think we really focus on mycophenolate or cyclophosphamide initially, then consider calcineurin inhibitors and B-cell targeting agents secondarily. This is really, again, highlighting this idea of potentially making more combinations work right off the bat. So I think the main inertia moving forward when we're treating lupus nephritis is that we need to use more immunosuppression and less glucocorticoids. So again, the current approach, the way I was trained, was again, you're going to hit them with quite a bit of immunosuppressive agents along with glucocorticoids initially. You generate the response, then you taper back slowly both the glucocorticoids and potentially immunosuppression over time. And then these newer guidelines, I think, highlight, again, this use of combining everything right off the bat, but using a lower glucocorticoid dose initially to achieve that response. And then you rapidly get the glucocorticoids off, and then you slowly reduce the immunosuppressives. So again, the emphasis here is going to be more immunosuppression right off the bat, potentially combination therapy, in order to then rely less on glucocorticoids. All right, so the winter of 2021 was interesting for lupus nephritis. We had 2 new medications approved for this specific indication. The FDA approval for Belimumab expanded from systemic disease to now also lupus nephritis in December 2020. And then Voclosporin was approved in January of 2021 for lupus nephritis. So just a little bit of background about Belimumab and the system it blocks in terms of B-cell biology. The cytokine that it binds to is BAFF or BLISS. It actually has several different names, as you can see in the first bullet point, because it's been cloned by several different groups in the late 90s. Pretty much the papers came out within a year of one another. It interacts with 3 different receptors that are differentially expressed on different stages of B cells. So a BAFF receptor is largely expressed on immature B cells. BCMA is another receptor that's mostly in plasma cells, and there's another one called TACI, which is expressed on mature B cells and plasma cells. The problem in studying the biology of BAFF is the fact that there's a related cytokine called APRIL. And so APRIL has different effects. It doesn't bind to BAFF receptor and has additional proteoglycan type receptors that it can bind to. And they share BCMA and TACI as co-receptors. But the tricky part is that BLISS and APRIL can heterotrimerize. BLISS and APRIL are part of the TNF superfamily member of cytokines. And if you remember vaguely, TNF is also a trimer and homotrimerizes with itself. And essentially what happens with BLISS and APRIL is that on the cell surface, they can heterotrimerize, so you can have 2 BLISS subunits and 1 APRIL, or 1 BLISS subunit and 2 APRILs. Then it gets cleaved off the cell surface to become a soluble cytokine. How those heterotrimers actually influence biology is not well established, and it's actually not clear to me how, if Belimumab binds to those heterotrimers also. I assumed it did. I just don't know. I don't think anyone has a clear idea about this. So this biology is complicated. And the other thing too I'm going to highlight a little bit later is that constitutive BLISS is made by stromal cells and numerous different lymphoid organs. So you always have the supply of BLISS. And which can increase during times of inflammation, produced primarily by inflammatory myeloid cells. Now, the thing is that the only thing that uses BLISS are B cells, all right? And I'm going to bring this point up a little bit later. So what does BLISS do based on what we know? So there's 2 main functions of BLISS. One is that it controls the survival of activated B cells, and this is really important in the germinal center reactions in the lymph nodes. So as you may remember, germinal center reactions are really the kind of cornerstone of B cell maturation and differentiation into either memory cells or antibody-producing cells such as plasma cells. And during this process, one of the most important things it does is that it edits its B cell receptor such that it increases its affinity for its antigen target. Most protein-protein interactions are in the micromolar range. If you look at the dissociation constant, antibodies tend to bind to its antigens somewhere between the nanomolar to even the picomolar range. So it's about 1,000 to 1,000,000 times tighter, right? And all of this occurs in the germinal center response. And how the germinal center rewards the B cell receptors that bind more with higher affinity is it improves its ability to survive. But there's a secondary factor here too, and this is going to be the amount of BLISS that's within the lymph tissue. So once a B cell gets activated during the germinal center response, it increases its BAFF receptor expression. And BLISS really is a survival cytokine. That's really kind of the core kind of home run point about BLISS function. It improves the ability of B cells to survive. So if you have more BLISS, you could actually have more B cells that should have not made it through the germinal center reaction make it through. So you can have a little bit of noise in terms of the optimal B cell receptors, and then as a result, antibodies are produced by those B cells downstream. How this applies in autoreactivity is a little bit unclear, but nevertheless, this is a clear issue. And so in lupus, where you have increased BLISS levels, so the higher BLISS levels allow for more B cells to make it through the germinal center response. As a result, you have more memory B cells, you have more plasma cells. And again, in the context of autoimmunity, this could lead to some issues, especially if the B cell receptor is autoreactive. Now, this goes back to the second function of BLISS, and this may be more important, is that BLISS impacts negative selection of B cells. So when B cells develop in the bone marrow, one of the most important properties of this development process is negative selection. What this process is that self-antigen is expressed in the bone marrow, and B cells interrogate the B cell receptors onto that self-antigen. If the signal is too strong, it is destined to die. All right? And this is how we eliminate autoreactive B cells. If the signal is not strong, it actually allows the B cell to pass and finish negative selection, and then eventually develop into an immature B cell, which then migrates into the periphery, mostly into lymph tissue. So when you have normal BLISS levels, most autoreactive B cells are terminated. All right, they die by apoptosis, and some of them still survive. Negative selection in B cells is actually pretty sloppy. Probably about 20% of B cells emerge as autoreactive still. So again, it's not a perfect system. Most of the controls on the T cell side here. But when you have increased BLISS levels, many of the autoreactive B cells that were supposed to die in the bone marrow now make it out to the periphery, okay? And so couple that with increasing survival of these autoreactive B cells in germinal center responses in the periphery, you can now start seeing a picture that when you have too much BLISS and you have too much B cell survival, these autoreactive B cells that should have never first made it out of the bone marrow and then secondarily never been activated fully in the germinal center response now can really exert its effector functions in the immune system and drive autoreactive conditions such as lupus. All right, so BLISS-LN is the phase 3 clinical trial of Belimumab and lupus nephritis. Again, Jason did a wonderful job on the Neph Madness website describing these trials, and it's funny because I had made this slide deck a few months ago, and when I read his commentary, I was like, wow, we're going to be talking about the exact same things. So if you don't end up forgetting some things about what I'm talking about today, just look at his blog post. It's really well done. So just a reminder, 448 participants with active class 3, 4, and or 5. They have to have a urine protein creatinine ratio of 1 gram or greater at screening. The glucocorticoid regimen is modestly aggressive. So 0 to 3 IV pulses of methylpred is sometimes it can exceed that threshold of 2.5, but here is up to 3. Prednisone utilization, again, this is a little bit higher than what we like. No more than 60 milligrams a day, but essentially 0.5 to 1 milligram per kg per day. But here they had a mandatory steroid taper to at least 10 milligrams or less by week 24. One of the interesting aspects of the study design is that it actually was made very early on in the early 2010s, and the study started actually quite early as a result. But it took a long time to finish because of enrollment problems and recruitment. And so I think if the study were redone now, the taper itself could probably be more aggressive. It may have chosen 7.5 or 5 milligrams as its threshold. The primary outcome here, and we'll discuss this just a little bit, is this renal response, which is a composite that was generated during the trial. Jason does mention this in the in his blog post about how this the traditional primary outcome of lupus nephritis trials are going to be the complete response rate, the CRR. That was changed for PERR mid-trial prior to unblinding the data. Some people have problems with that. I'm okay with it as long as the spirit behind it is because there were improvements in the way we can detect or how we can assess disease activity and efficacy. And we'll get into a little bit of this in a second, though. So anyway, the study design is graphically shown here on the right side. What's interesting about this trial is this is a 2-year trial, which is quite long for lupus nephritis. Most of them, the short end are 6 months, some of them are 12. So again, this is on the Neph Madness website, but Michelle Lim did a wonderful job of summarizing in this really beautiful visual abstract here. The background therapy I didn't mention, but is either going to be cyclophosphamide induction with azathioprine chaser or mycophenolate throughout. And this was importantly part of the investigator's discretion about whether or not they should be started on cyclophosphamide or mycophenolate. One could easily make an argument that this could lead to a bias in terms of what type of patients. I think most people would potentially start cyclophosphamide if they were sicker versus mycophenolate. And again, that was not controlled by the study, that was controlled by the investigator. But when you look at the two different response rate, renal response outcome measures, you can see there's a bit of a relaxation of the proteinuria. We'll talk about that in a second. There's a hint of a relaxation of the eGFR. Actually, the original complete renal response rate actually does a creatinine clearance, which requires a 24-hour urine. And so this was changed for EGFR, and again, both of them still share that no use of rescue therapy, which obviously surrogates for flare. But if with this change, you end up having some changes in the response rate. So of the people that were on Belimumab plus standard of care, whether a cyclophosphamide or mycophenolate, 43% were able to hit this primary efficacy and renal response rate compared to placebo, which was 30%. I think one of the interesting observations we always make in lupus clinical trials is that the placebo rate tends to be pretty high. It bounces between like 30 to 45%. I'm going to tangent here just for a moment because I think medical adherence is a major problem in lupus. When in our cohort of people who are prescribed hydroxychloroquine and we call their pharmacies and they do pick it up, when we check their blood hydroxychloroquine levels and we expect them to be over 1,000 milligrams per day, 70% of them are below 500. So there is clearly the majority of our patients that are only partially adherent to their medication. There is a huge financial incentivization in the clinical trial to take your meds. We've always wondered whether or not that plays a role in the placebo response, the standard therapy response. But anyway, this translates to a 1.6 increase in odds ratio in favor of Belimumab. When you look at the traditional complete renal response rate, you get rates of 30% for Belimumab plus standard therapy versus 20% of placebo for just the standard of therapy alone, giving an odds ratio of 1.7. And then when you look at risk of renal-related events or death, so this is a composite, clinically driven endpoint generated for the trial. This was largely driven by increases in proteinuria during the trial. That happened more in those just on standard therapy. When you add Belimumab on top of standard therapy, the hazard ratio drops by twofold. So I want to just highlight something about outcomes because I do think these outcomes do have a difference. So this is older data showing that you look at people with complete renal response versus partial renal response versus no response, the old traditional way of thinking about this. It's clear that more patients survive if they have complete renal response versus partial response versus no response, and there's fewer people that end up on end-stage renal disease if you have the complete response versus partial versus no response. All right. The issue, though, and this is from Jerry Appel's ALMS trial, that compared the non-inferiority of mycophenolate versus the low-dose IV cyclophosphamide regimen, is that very few people hit complete renal response. In his study, it was about 8 and 8.5%. I just showed you that in the BLISS-LN trial, it actually was about 20%. So I think over the past 10, 15 years, we have improved in some aspects our ability to be able to manage our lupus nephritis patients, but 20% clearly is not necessarily the end of the game here. And so I mentioned earlier about this threshold of 0.7 instead of 0.5 as a potential outcome measure for urinary protein creatinine ratio. And this was really generated by Maria Delaras and her colleagues' analysis of the Euro-Lupus clinical trial data. So again, the low dose IV cyclophosphamide. And what they found, they take every single biomarker, thresholded not just at various time points. What they found was that the single best predictor of long-term outcomes in lupus nephritis patients was the urinary protein creatinine ratio of 0.7 or less at 12 months after drug initiation. So this is just a raw curve showing the sensitivity and specificity numbers. It's not great. We traditionally teach that anything above 0.9 of a rock is optimal. This is, I believe, it was still like 0.84, I believe. But nevertheless, the thing is that the using this thresholding, this is still the best predictor. And again, this is state of the art, right? That we still are using proteinuria, and we have to wait 12 months. But nevertheless, this is still helpful from a clinical trial perspective, I think. So some newer data came out very recently. Brad Rovin was the first author on it. Came out, I believe, last month, where some post hoc analyses were done. And so I think what's interesting here is that when you look either the partial renal response or the primary renal response or the complete renal response rate, the one thing that really shows a group, subsets that do much better with Belimumab are those people with somewhat lower urinary protein creatinine ratios. So you can see here, if they thresholded at 3, those people on less than 3 versus those people that had greater than 3, there are some obvious differences between these two, so that the odds ratio of hitting PERR, if your urinary protein creatinine ratio was less than 3, was close to 2.5. When you look at complete renal response, it's around 2.2. And then also additionally in the post hoc analyses, Belimumab reduced the risk of eGFR decrease, the rate of eGFR decline, and the risk of first lupus nephritis flare after week 24. So I think when you kind of combine all of these data and looking at the systemic data, I think the systemic data tells us that the people who do best and respond best are those who have higher double-stranded DNA levels, who are hypocomplementemic. Now you add on the fact here that in those people with somewhat lower proteinuria levels seem to do better than those with higher proteinuria levels, you can already start to target what type of people you may want to use this as more of a first-line potential therapy as opposed to a backup. So the adverse events on the slide, there wasn't too many differences, and I would have to agree. I just want to highlight that suicidal ideation was a bit of an issue in the systemic lupus data, and anecdotally we've had a patient who had increasing suicidal ideation with a substantial depression risk in the past, that when we stopped Belimumab, that went away. I think the one thing I just want to highlight here is that I think we still have to screen pretty intensively mood disorder severity in these patients that we are considering starting. One of the things about systemic lupus is that mood disorders is part of the neuropsychiatric classification criteria. We actually have just published that we don't think this is actually true, that depression and anxiety severity does not correlate with disease activity, and they probably are separate, most likely due to health disparity issues. So this is just a home run issue here. When you're screening patients that are potentially going to be on this medication, you make sure that you have a good history of any mood disorders and severity of such. So just some final thoughts about Belimumab. It appears to be an effective for these specific populations add-on therapy to mycophenolate without any concerning safety signal at the population level. I wrote down mycophenolate because in point 3 here was that statistically there was a lack of effect in the cyclophosphamide group. I didn't really explicitly present that, but it is discussed in the Neph Madness blog. There are racial differences that could potentially be explaining this. The Black population in these clinical trials was very low. It's only about 13.7%. This again highlights the difficulty of recruiting Blacks into lupus nephritis clinical trials and lupus clinical trials in general. And I just talked about the bias in cyclophosphamide utilization. The dosing is a little bit different in lupus nephritis versus systemic lupus. The IV is the same. There's a loading every 2 weeks for 3 doses that first month, and then every 4 weeks afterwards. The sub-Q delivery, typically it's 200 milligrams weekly. What happens in lupus nephritis is there's a load, so instead of 200, it's 400 milligrams weekly for that first month, and then 200. Practically, our patients don't like to jab themselves twice a week for this loading if they want to do sub-Q. So what we do is we do the IV load, and then after that first month, we switch them to 200 milligrams sub-Q weekly. The main point I brought up earlier about damage is a major issue in lupus because many of our patients are living longer. So our discussions about expectations have shifted from getting them better immediately, but also thinking about making sure we attenuate and prevent issues long term. So damage is going to be this one issue that we'll have to see longer. It's going to take years for it, but I know GSK is looking at it. Cost considerations. 42% of lupus patients have issues with treatment costs, and this is something I'll bring up at the very end of the talk. So the other thing, and again, this is also in the Meth Madness blog that Jason had put together, was what if we do, what's the next generation of B-cell manipulation? Unfortunately, LUNAR for the clinical trial for rituximab failed largely because of, I think, study design issues, and especially a very liberal use of glucocorticoids in that trial. So basically, whatever signal rituximab generated got squashed into the noise because of the high use of glucocorticoids in that trial. But there's a theoretical advantage for using rituximab plus Belimumab. Remember, I told you earlier that Belimumab is constitutively made. It increases with inflammation. And I remember I also told you that the only sink for Belimumab are B cells. Well, not too surprisingly, when you B cell deplete someone, BLISS levels in the blood do increase. Now, you may look at this and say, okay, so this is on the far left side here. You can see that the majority of people pre-treatment of rituximab, and this is their serum BLISS levels, do go up after 3 months and then eventually goes down as the B cells start coming back. Now, you may look at the x-axis or the y-axis and say these are very modest differences. We're talking maybe twofold, maybe 3 or 4-fold for some patients. And I wouldn't disagree. The problem is that I'm not sure measuring serum BLISS levels is actually the right compartment. Now, like I said, I think the main action points are going to be within the bone marrow and within the lymph nodes, and we don't sample, cytokine levels in those compartments, at least not easily. So again, the surrogates for it, but it may not actually reflect the differences that are seen in the real important compartments. But nevertheless, we do know that BLISS levels do increase when you deplete B cells, which makes sense. So the other aspect here, so this is somewhat of a confusing chart here. On the x-axis is going to be the percentage of double-stranded DNA antibodies, which do go up and down with Belimumab treatment. And also somewhat with B-cell depleting therapies compared to pre-administration, which is going to be the 100 here, 100%, and then serum BAFF levels, which is going to be here on the y-axis. So what they did here was they took people who had 1 or 2 cycles of rituximab and either did better with lupus or had a relapse of their lupus. And this is coded somewhat confusingly. Those people with relapse are in the dark. Those people with remission are in the light or the clear symbols. But basically the bottom line is that those people who have been B-cell depleted, who end up doing worse, have higher BAFF levels or BLISS levels in the serum compared to those people who do better. So again, this somewhat highlights the need to be able to control BLISS or BAFF within the system in at least the rituximab treated groups. And the reason why this could be bad is that BLISS transgenic mice clearly develop a lupus-like syndrome with substantial glomerulonephritis. So this is just one of the several papers that came out on BLISS biology. But you can see that in BLISS transgenic mice, double-stranded DNA levels are substantially higher, and then they develop a really aggressive and rapid glomerulonephritis that kills these mice pretty soon after induction of proteinuria. So then the CALIBRATE trial was then initially started to be able to test this, and this was sponsored by the Immune Tolerance Network in the U.S. CALIBRATE just stands for a combination of antibodies and lupus nephritis, Belimumab and rituximab assessment of tolerance and efficacy. This is somewhat of a weird trial, a phase 2 multi-center randomized controlled open label trial in prior cyclophosphamide or mycophenolate users that have failed and as a result have been termed refractory lupus nephritis. All these people had some proteinuria over a 24-hour urine. The kidney biopsy had to be done within 18 months, so this is a pretty long time point. The study design here, or at least the timeline, is interesting because you can see that rituximab with some methylprednisolone was given initially for the first 2 doses in a traditional rheumatoid arthritis dosing regimen. On top of that, they had to be on cyclophosphamide, and the FDA mandated the addition of cyclophosphamide largely because rituximab did not meet its endpoints in LUNAR. So really what you're studying here is rituximab plus cyclophosphamide plus placebo versus cyclophosphamide plus rituximab plus Belimumab, all right? And you can see this is a lot of therapy. So the prednisone was fixed at 40 milligrams at the initiation of the trial, had to be tapered by week 12 to 10 milligrams, and then up to the investigators to reduce it below 10 throughout the duration of the trial. Originally, it was a 96-week trial. Belimumab was stopped actually at week 48, and then most of the data that is out is from either 24 or 48 weeks. The longer term data has not been released yet. The study continuation criteria are here. If you don't have an improvement of UPCR at week 24 of at least 25%, renal flare, select adverse events. The primary outcome of this trial was actually safety, not efficacy, which I think was pretty smart. And then also investigators' decision. The other aspect here, no other immunosuppressants are allowed. All right, so if they had to start an immunosuppressive, new immunosuppressives, such as mycophenolate or something else, because of a renal flare, that they were considered a failure. So just to be able to show you the people on rituximab plus cyclophosphamide, this is the RC group, versus rituximab cyclophosphamide plus belimumab, it's the RCB group. You can see here that the mean UPCR between the two groups is actually pretty similar, but in the rituximab cyclophosphamide group, they had a greater percentage of people with higher UPCR ratios of 3 or greater compared to those in the RCB group, which was somewhat unfortunate for them. So again, the primary endpoint is infectious adverse events of grade 3 or higher in the first 48 weeks of the study. You can see that within this particular outcome, interestingly enough, more people had infectious issues if they are on Ritux plus cyclophosphamide versus Ritux plus cyclophosphamide plus belimumab. I'm not exactly sure how or why this is possible. I would imagine that the Ritux and cyclophosphamide would be the greater burden. I can't imagine that belimumab would actually decrease it, but nevertheless, this is what was observed. When you look at B-cell reconstitution rates, this definitely slowed down. And this is part of the reason why it was a safety study, because there was a theoretical disadvantage that if you add belimumab after rituximab, it'll take longer for B-cells to replete because there isn't that super physiologic level of belimumab, of BLISS. Now it's more physiologic. So you can see that almost all these people depleted their B-cells by week 12. But when you look at B-cell numbers downstream, you can see in those people who got belimumab, they stayed very low throughout the trial, up to 60 weeks, while you can start seeing rebounds going back up at 60 weeks in those people that did not receive belimumab. So this demonstrates the slower kinetics of B-cell reconstitution. On top of that, I'm going to focus on B here, is that the number of ANA positive naive B cells decreased. So the transitional B cells are going to be those that are predominantly within the lymph node, ready to participate or participating in germinal center reactions. Those did not change, but of the B cells that came out of the bone marrow introduction into the lymphoid tissues, you can see that most of the people on belimumab had decreases in ANA positive B cells, whereas a fair number of the people with on just rituximab and cyclophosphamide had increases. So again, this works with, and this is kind of more of a proof of concept about the entire issue about what happens with negative selection here, is that, again, when you add belimumab, you should anticipate a decreased rate and a decreased proportion of autoreactive B cells emerging out, and indeed that is what they saw. The efficacy endpoint was this complete renal response rate. No difference was really seen between the groups, either at 24 or 48. Oh, here, they do have 96 here. So, I think what this highlights again is that because it is a safety, study, they didn't really power it forward to be able to demonstrate efficacy. But that would have required a massive number of recruits into the study, largely because there's so many other background meds of Ritux and cyclophosphamide. To be able to see a difference additionally with belimumab would have been challenging. So I'm going to switch gears and spend the last 10 minutes here on Voclosporin. This is the new calcineurin inhibitor on the block. Essentially, this is just a structural derivative of cyclosporin. It's just the addition of the methyl group at the first amino acid. This simple chemical change does change quite a few properties of it. There's increased potency, and I'll show you in this next slide. versus cyclosporin at a per milligram level. There's less pharmacokinetic variability, so as a result, you do not need to monitor blood levels for this. And there's an argument for less metabolic side effects. There are data demonstrating that there's no changes in, say, magnesium levels or potassium levels that can be issues with legacy CNIs. So just to be able to show you here some MOI, the CNIs in general have been traditionally thought to be immunologic modulators, mostly by reducing T cell activation. And so by doing that, you're able to reduce cytokine production. We typically think of IL-2, which is your T cell growth factor. But on top of it, it has independent effects on T cell proliferation and also reduces co-stimulation molecule expression of T cells, which is which was that second signal that is required for full T cell activation. So theoretically, when a T cell that doesn't have that second co-stimulation signal gets stimulated by a cognate antigen on an antigen-presenting cell, it actually will energize or essentially functionally mute that T cell instead of activating it. But of course, there's a non-immunologic mechanism of action here that has been described well described in vitro, and this is essentially the preventing the dephosphorylation of a slit diaphragm of synaptopodin, which is one of the major anchoring proteins for actin that connects it to this to the nephron slit diaphragm. This entire complex, there are numerous proteins involved, but one of the things that happens from the transition of normal foot process morphology to foot process effacement is that synaptopodin gets dephosphorylated, and as a result, you lose the structural integrity. This is shown here. This is actually mouse glomeruli, but this is no different than in humans. These are scanning EMs of mouse glomeruli from a healthy kidney. Here you can see those beautiful slit diaphragms, and again, to kind of think about it graphically, is that it's almost like your fingers, and they intercalate with one another, and the bones in your fingers are essentially that actin bundle that keeps that structure together. And when synaptopodin gets dephosphorylated, you lose the actin. All of a sudden will start changing its form from these actin bundles and to more of kind of a lamellipodia type of structure, and as a result, you start losing your finger type structure and becomes more effaced. Where this is now the foot processes, but essentially they kind of blend into each other, not into each other, but they basically blend, and as a result, you lose that morphology. That particular morphologic change is strongly associated with proteinuria. Exactly how is actually not really that clear to me, but nevertheless, podocyte injury generates that particular type of a phenotype. And again, this is just showing a transmission EM of that actin bundle here in the foot process, and graphically shown here. The slit diaphragm is here, which is just nephron binding to one another between two different podocytes. This is where synaptopodin would be located in this black blob, and then you have a colloidal actin network with this actin bundle kind of loosely associated with it. And again, when you have injury, this essentially dissociates, and as a result, you start having some very loose structures that demonstrate this effacement. Now, the reason why podocytes are really important, I think, in most glomerular diseases, particularly the proteinuric ones, is that there have been studies demonstrating some sort of a relationship between kidney function and glomerular loss vis-a-vis loss of podocytes. And so this is best demonstrated in IgA nephropathy, where urinary epithelial cell number, so this is the amount of podocytes within the urine, somewhat correlates with GFR, I'm sorry. So this is actually from biopsies, and this is where you have reduced podocytes that are observed by histology. And so when you have fewer podocytes, your dissociates with reductions in GFR. Similarly, there's an inverse correlation with the fewer number of podocytes having increased global sclerosis. And this has been kind of envisioned as a model by Hans-Joachim Anders, who had this nice little review in Nature Review Disease Primers a couple of years ago, showing just, when you have gradual aging, normal aging processes that allow for podocyte nephron loss, when you have a lupus nephritis flare, that greatly accelerates the loss and of podocytes and nephrons. But if you're able to limit that, then you're able to maintain the same slope as the ones without lupus nephritis. But if you have additional insults, additional flares, you start really dropping this down much more quickly. So one thing I want to highlight here is that cyclosporin can decrease mycophenolate levels in the blood. This is largely due to the fact that cyclosporin inhibits the multi-drug resistance associated protein 2, which is the MRP2. This is found in hepatocytes, and essentially of its many functions, one of which is actually it spits out drug metabolites into the bile. And so cyclosporin can increase this, and so as a result, you can have decreased mycophenolate levels in the blood. For some reasons, this simple chemical modification, voclosporin, does not. So just a quick review of the study design, active class 3, 4, and or 5 with 357 participants. This is a 1-year trial initially. Higher protein creatinine ratios were needed for entry. The glucocorticoid regimen was more aggressive here. So I think the home run point is that there was an optional taper to 2.5 milligrams a day by week 16. Most patients were actually able to hit this, even though it was optional. So again, this highlights the ability to be able to reduce steroids while still trying to generate efficacy. So again, Preeti Meena has done a wonderful job with this particular visual abstract. And here, when you look at complete renal response, they did not use the PER that's specific to GSK's trial. But here, using the CRR, you can see that of the people at week 24, you had almost a third hitting CRR versus 20% in the standard of care. This increased to 41% at 1 year if you had voclosporin on top of standard care. So this standard care is mycophenolate versus just mycophenolate alone. I think this is super impressive because, again, remember the Allen's trial, we saw 8%. In the BLISS trial, we saw 30%. Here now you're seeing 40% CRR, which is very impressive. Serious adverse events were equal between the two, but we'll talk about some specifics here in a second, and they had more deaths in the placebo arm. So there were some differences seen in different groups. For example, whites did not hit statistical significance, and this is not because I don't think it didn't work. I think here they interestingly saw a very high placebo response rate with, and again, this is mycophenolate background. This actually doesn't jive necessarily with some of the ideology that we have in lupus nephritis, where we believe that mycophenolate is better for blacks and Hispanics versus cyclophosphamide, which is supposed to be better for whites. Here we saw some kind of a different response rate here with the mycophenolate. So anyway, it definitely works in the minority populations, maybe potentially less well for the white populations. And also here, compared to Belimumab, which works very poorly in class 5, here you're seeing some effect, although there's definitely a wide spray here in terms of the error bars for class 5, but for the other classes, you can see that there's it works generally well for the other ones, including mixed proliferative plus membranous lesions. The use of mycophenolate as screening, here you can see that those people that were on mycophenolate did better than those that did not, who had mycophenolate. And it was actually those people who were on mycophenolate at 2 grams or less who did better versus those who were 2 grams or greater. This probably reflects potentially disease severity more than anything else, though. And so, but nevertheless, I think the combination of voclosporin with the mycophenolate is actually very, the data is quite impressive. You know, the adverse events, I think, has been well described for CNIs, both the acute and chronic. And so the acute nephrotoxicity in CNIs is definitely seen here. The vasoconstrictive effect of CNIs is definitely seen. There's a decreased EGFR seen in 26% of the people in the study. 19% of them had hypertension. Now, what's important here, I think, to highlight is that this occurs early within initiation of drugs. 71% of the study participants had the decreased EGFR noticed, and of those people, a little over 3/4 of them had it reversible. Now, that still means 1/4 of these people had more durable reductions in EGFR, which is going to be is somewhat concerning, and this is something that would have to be discussed with the patient to be able to see make sure that expectations are set. As a result, dosing adjustments are required for those people with reduced eGFR of less than 60. So, and it's somewhat complicated, but you can look at the product label to be able to get to that. The monitoring requirements for rheumatologists is a bit of a, I wouldn't say a challenge, but it's a bother. Check eGFR every 2 weeks for the first month and monthly afterwards. Blood pressure every 2 weeks for the first month and then clinically indicated afterwards. The fibrotic type of issues that's seen with chronic CNA-associated nephrotoxicity, totally unknown though. There's a long-term extension, which actually maintained a control group here, which is somewhat unique for a long-term extension that now goes out to 2 years. Some interim analysis at week 30 within this long-term extension was presented both at the American College of Rheumatology and I believe at ASN also, and also a press release that's linked here. The top line results here is that the eGFR is relatively stable over time. Slight reduction in those people on Voclosporin versus just mycophenolate, but nevertheless it's somewhat similar and stable over the time points. UPCR is lower in the Voclosporin group at all time points compared to those just on mycophenolate. No differences in adverse events were presented in the press release, although the data itself has not been presented. There was a similar withdrawal rate between the two groups, and interestingly, in the long-term extension, 4 deaths were seen in standard care versus 0 in the Voclosporin plus standard care. So just some final thoughts here before we wrap up. There appears to be another effective add-on therapy to mycophenolate with some largely reversible safety signals associated with the acute CNA-associated nephrotoxicity at the population level. There's always this discussion, is there really a difference between Voclosporin and cyclosporin? And this is probably something we can talk about in the Q&A. And I know in the lupus, bracket and Neph Madness that, it's going to be, Belimumab versus Voclosporin. I think the two could be used safely together theoretically, and this is something that I think a lot of people have been discussing with the idea of using Voclosporin as an induction therapy and keeping it on for 6 to 12 months while having Belimumab also added on as induction therapy, but that's maintained through as maintenance therapy. Dosing may be challenging for some lupus nephritis patients. There's a pill burden issue. The full dose is 3 capsules twice a day. If you're on full dose mycophenolate plus a hydroxychloroquine plus an ACE and an ARB, this translates to about 16 to 20 tablets a day on top of everything else that they're on. So this is going to be a problem. We don't have any idea similar to Benlysta or Belimumab about renal damage reduction. I'm sure this data will come out also. And again, like I mentioned, no idea about chronic CNI associated toxicity. Cost considerations. So ICER, this Institute for Clinical and Economic Review, has this threshold of $150,000 per quality adjusted life year. So ICER's framework basically drives an assessment of this thing called care value. It's based off of comparative clinical effectiveness like safety and efficacy. There are other benefits or disadvantages such as new mechanisms of action where other traditional therapies may fail. Contextual considerations like high illness burdens, the lack of alternative treatments, and then incremental cost per clinical outcomes achieved, which this QALY is one of those measures. So when you look at the cost, Belimumab is about $10,000 the first month and then about $3,500 each month afterwards. Voclosporin with a presumed 22.5% discount is a little over $7,500 per month. So when you look at, and when they calculate this out, you can see that the this threshold of $150,000 is technically met by both, but it is cheaper to meet that with Belimumab compared to Voclosporin. So it still highlights how expensive Voclosporin is. I'm not saying Belimumab is cheap, but again, this is something that needs to be considered in the overall equation here. So just to wrap up here, again, we're still rethinking, we're still modulating, we're evolving our therapy, our approach to treating lupus nephritis. And again, everything points towards the targeted therapy. So again, Maria did a nice job of presenting this. Stratifying lupus nephritis patients is going to be incredibly hard because it's technically a rare disease. So it's going to be something that we're going to have to figure out, sophisticated analytic strategies to be able to figure out how to match the right therapy to the right person. And this is then going to be confounded or clouded by the phase of disease induction versus maintenance. And then we talked about a little bit earlier about, do you do single versus combination versus sequential? I think combination now is in vogue, and we may find that this is actually not the right thing to do in the future because of toxicity. Again, time will tell. Timing, like how many conventional drugs do you use before you start using more novel MOAs? Sometimes insurance companies will dictate that more than anything else. How long do we treat? Is drug withdrawal safe? I can tell you that when you withdraw hydroxychloroquine, bad things happen. There's recent data from France that definitely shows increased flare rates. So this is that's certainly a drug that we can't withdraw. And of course, we need to figure out how to diagnose lupus nephritis earlier. We always talk about timing of biopsies, but I think one of the things that we've been looking at is novel imaging approaches. So this is just a mouse that has glomerulonephritis induced by nephrotoxic serum. And what we did was we injected a tracer that gets activated by activated macrophages in the kidney. And so in non-glomerulonephritis mice, you don't see a signal. But you can see here, this is a fluorescence molecular tomography approach, where basically you are taking the mouse and imaging for fluorescence signal inside the mouse. You can see that it actually highlights the kidneys really well. So there are a lot of emerging approaches about thinking about how to diagnose or at least identify inflammatory changes in tissues such as the kidney that could then potentially allow us to be able to more selectively or better identify people for biopsy. And then there's this last paper I want to quickly chat about. This is really problematic to me. So essentially, this is a Brazilian cohort in Sao Paulo, and that Brad Rovin helped kind of characterize and help do the analysis. But basically, these are people without proteinuria who had systemic lupus erythematosus, who had biopsies because they had microscopic hematuria. And of these people, I'm just going to focus on those people with low proteinuria levels. You can see that 75% of them had proliferative lesions. So they had microscopic hematuria, they had proteinuria less than 0.5. All right, and they still had proliferative lesions. I don't know what this means, and this is kind of an issue when we're focusing on proteinuria as an outcome measure potentially. So again, this is going to change very rapidly in the future. It's an exciting time for lupus nephritis, but I think it's going to be very confusing for a lot of people in the short term as a lot of these targets are being brought out and trying to figure out what type of patient is best for what type of medication. That continues to be a challenge. So with that, I want to thank you for your attention, and we'll open up for discussion.
Thanks, Al. That was a wonderful overview of the science as well as the clinical trials. I'm sure there are many people with questions, so feel free to unmute yourself or raise your hand, and we can go ahead with some Q&A. Yeah, David.
Hi, Dr. Kim. Really fantastic talk. I'm a nephrologist here in Ottawa. I wanted to get your thoughts about Voclosporin. I don't understand why it was studied against nothing. Well, not nothing, but kind of just a placebo essentially, and not a conventional CNI, because I find it hard to justify using a drug that's much more expensive than conventional CNI just for not having to monitor levels. And, once you get patients on a good level, you don't really need to monitor that closely their levels anymore. It's just kind of hard to justify something so expensive.
I think that's a great point. And I think that what the trial would needed to be done would be 3 arms, right? Mycophenolate, cyclosporin, mycophenolate, voclosporin. That, in retrospect, that's what should have been done. And I think if we had the resources and academics to do it, we would have done it that way.
Do you know if it wasn't because there's quite a few trials out of China mostly looking at tacrolimus as an add-on to standard therapies that have already established that it's it's effective. Is it because maybe when they were conceiving this they didn't have that data, so they didn't why it wasn't done in the logistics of the trial design?
I would have to defer to the people at Aurinia. I think there are competitive reasons. There are, let's just leave it at that. But I 100% agree with you, and I think as a rheumatologist, we don't use CNIs, all right? We don't. So, we're like, oh, wow, Voclosporin, this is what a new kid in the block. But the reality is that it's a derivative, right? Are we moving laterally or are we moving forward? It's not clear to me. So.
Thank you.
Dr. Fairhead.
Hi, thank you. That was a great talk. I'm here with a few residents. Yeah, I'll make one comment on Voclosporin. I'm going to date myself, but it was actually where I did my nephrology fellowship in Edmonton, Alberta. It was actually the start of Voclosporin, and it was trialed in transplant, right? And there was no difference between Voclosporin versus cyclosporin in clinical trials. So if we want to extend that a little bit, you could argue that cyclosporin should be the same as Voclosporin for outcomes, even though we haven't looked at it specifically in lupus. One question for you, or two kind of comments, and I'm interested in your opinion. The first is, whether we're talking about, complete response rates or this partial efficacy response rate, those numbers are still pretty low, right? Like, when we look at our other GNs, like ANCA vasculitis or membranous, we're wanting response rates of 70 to 80%. And here we're seeing response rates. We're excited by 30 to 40% response rates. And I think that's a problem. But you also highlighted how difficult it is for compliance. And should we be looking at that when we're building these clinical trials? Like, should we be looking at pills that have, 2 or 3 drugs together? Should we be really looking at patients and asking them what's going to be acceptable to them? Because maybe if we could improve compliance, that would improve our numbers a lot more than brand new drugs that cost $100,000 a year.
Right. So I think both your points are 100% valid. I think with the first point, it always comes down to are our current parameters of outcomes, or judges of outcomes, are they really gold standards? All right. And so if they aren't, and you're close to 80%, then you're actually moving in the wrong direction, I think. All right. So that, again, 50 years from now, we'll have some answers. Right now, I have no freaking clue. All right, so but it's a great point. And we have this problem in systemic disease. Our systemic instruments to assess disease activity absolutely suck. All right, yet we somehow use them. All right, imperfect as they are. The second point, I already forgot what it was. Oh no, it was the pill burden issue. So I think if you were a computer game like The Sims, this is the ideal way of giving meds, because you can titrate the medicine. All right. So this was largely the reason why they don't have a 26.7, whatever the 3 dose was, 7.9 times 3, who knows? But the thing is, they don't have that strength of capsule because there's such fluctuations that can occur with GFR potentially, right? That has to then be accounted for dosing. So the best way to do it from a safety perspective is to tell them how many capsules to take, rather than saying, instead of taking the blue one, take the red one, all right, where there could be some confusion, all right? So I think the reason why it's done that way is mostly to be able to titrate out in a more safe way. But again, the practical implications of that are problematic. I 100% agree with you.
Any other questions from anyone? The whole thing about using cyclosporin or tacrolimus has been the recurrent theme, right? It's just so expensive, Voclosporin, that I suspect people are just going to off-label use these other CNIs. But the science behind Benlysta, the Belimumab, is also fascinating. I mean, you've been using it for a while. We haven't used at all. Do you have any pearls or nuggets that would be useful, and if whenever it becomes easily accessible for us to use it?
Yeah, so I'd like to get Catherine's opinions here too. I mean, I know it's somewhat constrained, its utilization in Canada, but I think we were just chatting before the talk that I think of the people that do well on Belimumab for systemic disease, they do really well. I mean, we have some patients who were in the original lupus clinical trial, Belimumab clinical trials, and now are hitting close to 13 years on it with excellent disease control. All right, so that's impressive. The other aspect, though, too, is that in lupus, IV delivered or injected medications are not culturally accepted as well as it is in RA, where we've now have had things like etanercept and infliximab for 20 years. The only other IV drug that's largely given is cyclophosphamide. And when you look at Reddits, subreddits in lupus or chats and stuff like that, they are looking at Belimumab kind of like, oh, is it going to make me as sick as cyclophosphamide because I didn't like that? All right, so again, it's just more aligning patient goals. The other aspect here too, we had one patient, it's been reported, there was an abstract at the American College of Rheumatology recently about this, about de novo lupus nephritis while on Belimumab. And so we've had one patient where this occurred. Rare, right? But again, who are those people? All right. And then what implications does it have at a much larger population level rather than hundreds, thousands, tens of thousands with existing lupus nephritis? All right. So I think that's a fascinating question. But generally, safety, which is the first thing that patients ask about first, they assume it's going to work if I present it to them. But safety-wise, I think is one of the most predictable drugs we've had. Like, it's pretty clear that the safety signal is consistent across all the clinical trials, and that does play out in the real world too. I do perceive it as one of the safest drugs we use outside of hydroxychloroquine in lupus, systemic lupus.
I'll just comment quickly, but yes, thanks. That was an excellent overview, and always need to remember what all these trials did differently in the outcomes. But in Canada, like we were alluding to, the only patients who have access to Benlysta, it also depends from province to province, but in Ontario, it's only ones that have private insurance that will cover it. And at that, it's not every insurance company that will. So I have about 300 lupus patients. I only have 5 on Benlysta. So I don't have the numbers to really give a good kind of clinical overview of how it works, but the ones that are on it do have really good musculoskeletal response, skin response, and we haven't used it just for nephritis yet. But it's an access issue for us in Canada. It's going to be the same thing with Voclosporin. But I think, like you were saying, the ones that can take the drug and do well, I've had most of those patients be able to come off prednisone, which is huge, right?
Yeah.
David, you had another comment. I guess we'll take that as the last question because we are over time. Go ahead, David.
Sorry, Dr. Kim, just wanted to get your how have you been using Belimumab? Are you using it right up front for lupus nephritis in combination? I spent some time at UNC and we were doing that for a few patients, but the way I'd see it, and certainly, in Canada, since it's so difficult, it'd be something, you try maybe the standard for a few months, and if you see you're really going down the wrong track, you want to try add something on. But are you using it like right off the bat, kind of as in the trial?
I do present it. Of course, shared decision making plays a huge role in this. And we do have a couple patients where it is part of the induction therapy program. Again, we do have that culture of kind of IV or injectable avoidance in lupus still. So some of them are like, yeah, I'll take the pills, even though there's a lot of them. And so, even though we try to paint it that, we could potentially achieve outcomes a little bit faster, theoretically, so, again, we're still kind of playing around with it in a real world setting. So all I can do is really provide antidote, which, as we all know, is not data. So, yeah.
Fantastic. Thanks again, Dr. Kim, for that wonderful overview of the science and the trials. And hopefully we'll do many more such rheumatology, nephrology grand rounds in the future.
All right.
Thank you.
Thank you.
Bye-bye.
Bye-bye.